Good afternoon and welcome to Senate Health and Human Services. It's good to be back. Before we get started, I'm going to ask Senator Avar to lead us in the Pledge of Allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which stands one nation under God, indivisible, with liberty and justice for all.
So I'm going to open the hearing and I'll take a motion to go into executive session. I have a second. All those in favor say aye.
Aye.
All right. Welcome back.
Welcome back.
Your dream was
Take
later.
Come on.
Andre, we'll sing.
I'm not a singer.
No, you don't want me to sing.
I'm not a singer. You don't want me to
They
sing.
won't let me in church.
All right. Let's start with House Bill 126.
We just go straight into it.
Yeah, we're in exec right now.
Did I miss that?
You missed that.
Jesus, I'm singing, I'm sorry. Okay, we're in.
Yeah, that's singing. You gotta watch out for that. For executive session, House Bill 126.
So I'll make a motion, because I know that there's an amendment for an OTP, so you can introduce it. Oh, sorry. All right, getting back into the groove. So I'm gonna make a motion to OTP. For the,
I'll second.
and I know there's an amendment that Senator Rochard has brought forward.
So, yeah, so we've got a motion and a second. I'm gonna move amendment 2025-3020S.
Second.
Get a second. All right. So if you recall, if I may speak to my motion,
You're the chair.
my committee. It's been a while. I'm out of practice.
I know, we're all getting back into the groove
I
here.
barely had a handle on it before we left here. So if you recall, House Bill 126, a couple of years ago, we changed the law that would allow a dispensing of a 92-day supply of topically applied androgen for the treatment of chronic low testosterone. This Bill 126 would expand that to injectable androgen for the specifically for the treatment of chronic low testosterone for a 92-day supply. The original bill was really cumbersome. And if you recall, the parameters for using the injectable versus the topical is that the prescription includes a statement by the prescriber that the medication is to treat chronic low testosterone, which on line 15 of House Bill 126, it really has that requirement that it is used for that. And the part that really got, I thought, for lack of a better word, wonky, and it required the patient has previously filled 12 prescriptions from the same medical practice for a monthly supply of medication. And in looking back at what the standard of practice is for pharmacy and dispensing medications, that is unique to everything else in statute and law. And quite frankly, I don't think it's necessary. And the reason I don't think it's necessary is because testosterone is a drug that would be recorded in the prescription drug monitoring program. So if the concern was that there's doctor shopping, that people are moving around from physician to physician, that would actually be seen by the prescribing physician, and there would not be that that concern would be met with practices that are currently in place. So the amendment that I had just matches, lines up the topically applied androgen to the injectable, which just says it can prescribe for prescriptions for injectable androgen prescribed for the treatment of chronic low testosterone may be filled for up to a 92-day supply. And again, just for the committee's sake, oftentimes these are prescriptions that are delivered in a 1 milliliter dose once a week. And the bottles that they come in, the standard bottles are 10 milliliter bottles. So clearly the manufacturer has made this in a way that is, can be done. So that's what the amendment does. And I don't know if there's any further discussion on that. Seeing none, I'll move the question. All those in favor?
Aye.
Any opposed?
Consent?
Second.
And consent, so we voted on the amendment. We have to vote on the bill too?
Yeah, we're gonna underline.
Oh,
the amendment, then
All right. So then move, okay. All right, the motion is ought to pass as amendment. So you've got that then?
so moved.
All right. So we got a motion, second, I'll second that. So ought to pass on amendment. All those in favor say aye.
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 Any
As
opposed?
amended, right?
As amended,
Yeah.
correct. Any,
PPA.
no opposition. I heard Senator Avard move for consent.
Ditto.
Second.
Senator Bertzel seconds that. All those in favor say aye.
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 Opposed? All right. I'll take that out. All right. Moving on to House Bill 705. I'm going to move ought to pass on House Bill 705. Do I have a second?
Second.
So this relates to healthcare cost transparency, and if we went back to the hearing report, we held on to this contingent to stuff that was happening on a federal level regarding Executive Order 14221. I did ask the Commissioner of the Department of Insurance to come and speak to this, because I know it was, when I was going through these bills, I quite frankly couldn't remember the discussion around it, aside from what was in the report. I know the Commissioner had agreed to come in, and here he is. So if you could just bring us back up to speed on this, Commissioner, please.
Certainly. Thank you, Mr. Chairman, members of the committee. Nice to see you all. Hopefully you've had a good summer and fall. So I'm joined here at the table by Dr. Jason Azis, who is the director of our data analytics unit. I'm going to try to just level set very quickly without replaying the entire public hearing over again, which I'm sure you would not appreciate. So what we're looking to do here is to advance the department's longstanding work as it pertains to transparency in health insurance. And so the three key components of this proposal is that it requires every health plan and carrier to publish their in-network rate file, so the negotiated prices for all covered items and services, the out-of-network allowed amount file, which is to say the billed charges in average allowed payments to out-of-network providers, and then the prescription drug file. As that data is collected, the bill will then sets forth that data will be presented in a standardized format, that it will be made available to the public. It will be overseen by the New Hampshire Insurance Department, which I think is always something that we prefer to have the ability to do, as opposed to deferring to the federal government's jurisdiction and oversight. Whenever issues come up, whenever questions arise, it's a lot easier to work with our department than it is to try to work with the federal bureaucracy. So that is at its core what we're looking to do here. There are some additional safe harbors and flexibility for the carriers. It recognizes temporary technical or data challenges. It provides good faith compliance protections for carriers who are acting in good faith to reasonably and diligently get into compliance, but for whatever reason may be a little off the mark. We have the ability to work with them in a non-punitive way. And it allows us to satisfy the obligations through third-party administrators clearinghouse. We can bring in experts in the event that we need to. So, Mr. Chairman, as you pointed out, at the time the bill was originally brought forward, there was some uncertainty as to exactly what the federal government was going to do. The federal government has gotten a passion for price transparency. That is great. We welcome them to the party. But we were waiting on some rules to come forward, what those rules would look like, whether or not they would be subject to litigation, as seems to be more and more frequent these days. So we asked that it be held on to so we could see if and when some of those questions were answered and how exactly they were answered. As with all things Washington, I'm not sure it got any clearer, perhaps just more confusing. So one of the provisions that we did put into the bill in the House that is now before you is a provision that says that in the event that anything in our bill or in the rules that we promulgate are at odds with what the federal government ultimately sets forth, we will default to what the federal government sets forth, so that you're not having to deal with any issues of duplicative work or there being provisions that are at odds with one another. And really also, I think by including this provision, sidestepped any issues around federal preemption. Those are battles that I don't think are worth having. I think whatever the feds put forth, we'll find a way to make it work, as we always have. New Hampshire, as I said, has a long and proud history of being on the cutting edge of transparency efforts. We're a bit of a subject matter expert in that field as a department. So we'll find a way to make that work, whatever the federal government brings forward. So we will be ready. We will be ready for whatever comes forward. So from our perspective, because of that provision, this bill, we feel, is good to go. Anything to add? Great.
Senator Prentice.
Thank you, Chair Rochford. Gentlemen, welcome back.
Thank you.
Good to see you. So October 1st is when we were waiting for some regulatory provisions. Those are out. Now we're in a kind of a whole governmental holding pattern, but these are expected to take hold. Say we come out of this pattern sometime in February. So my first question is, and maybe it's, are we gonna be okay in February? Do you believe that the way the House amended it would allow for some flexibility? Not even knowing that we were gonna have this, be in this holding pattern? Is that what I'm hearing from you?
That's right. And I think that we're going to obviously be practical and reasonable about how we approach this. The federal government shut down right now. Who knows when it will reopen? Who knows what that's going to do to timelines or prospective timelines? We will wait for the appropriate time when we feel as though the dust has settled, when the guidance has come forward, whatever that's going to be. And at that point, we will begin the process of working collaboratively, as we always do with the carriers, to see exactly what compliance is going to look like, the different formats of all of that. So we're not going to rush forward until we've got more certainty, but it will be very helpful to have the statutory authority in place so that when those unknowns are better clarified, we'll be ready to go, certainly much, much faster than a lot of other states. But one way or the other, this is coming. This is going to be a federal requirement the carriers are going to have to abide by. As I said, I think what we're doing here is ensuring that it is a process and that the oversight functions of it are done here at the local level, which I think is an advantage and a benefit to the carriers, as opposed to trying to decipher and interpret the tea leaves of the federal bureaucracy in Washington. Anything more, Jason, on that? Go ahead.
No, I think the key point in the department's interest is centered around the comparability across the different actors in the health insurance market. And the federal government really, I think, failed to specify a standard format across that unit of analysis. And as such, we've worked with some of these data already, but it's very heterogeneous, different across all of those actors, and it renders the comparability, we're unable to compare across actors because of that. And that there's language in there that kind of specifies that the purpose is to be able to compare across all submitters of data with the same format. And that's really a key but subtle provision that will help improve the utility of this important information.
Senator Prentice, do you have a follow-up?
Just to follow up, slightly different, but let's go over to, I mean, so I'm all for transparency. I applaud your efforts to move this forward as well as the federal government's. We have New Hampshire health costs, and I went back to that. And maybe when you're talking about the different actors, Dr. Aziz, you're talking about you're talking about this, but have we crosswalked what's the same and what's different? Like, do we know what the impact will be on the carriers to come into compliance?
Yeah, thank you for that question. They're in material compliance already on their own websites. They post this information, but it's in very different formats. The New Hampshire health costs data is empirically based. That's using claims data. We post the median paid amounts for actually a small cohort of healthcare services, 300 healthcare and dental services combined. There's well over 10,000 that our citizens are exposed to. So this new advent could be actually used to inform our citizenry what they might expect to pay for all of these services, not just those that meet the eligibility criteria and the statistical criteria to responsibly post them as prices. So that's one of the key areas of our unit's interest in that, is to improve the utility of the healthcare cost estimation across all carriers.
Another follow-up.
Thank you. So, thank you. And what I believe I've heard in here is that you've had conversations with the carriers so they are understanding how this is going to be implemented, and you're building in again flexibility. So there's not a punitive nature to this, but we can still achieve that. I mean, I believe that New Hampshire has, as Commissioner you said, I think we have a high bar on transparency, and in comparison to other states, I believe that we really do when it comes to costs around healthcare. So, with that said, where can you just summarize your conversations with the carriers?
And so I don't want to mischaracterize. I mean, they're not pleased with the extra work that's going to have to go into putting all of this information together. It's going to be a burden for them. I'm sure there'll be a cost associated with it. But as I said, it's not a cost that's going to be driven at the state level. I mean, it's going to be a requirement that the federal government is going to impose on all of them across the nation. And it really comes down to, who do you want being in the lead position to make all of this work, the federal government or the state? And again, I think that our approach to collaboration and working with the carriers is a benefit. It will make it go smoother and be more effective ultimately for the consumer. But also they know that that we're very experienced in this area. So we know what we're doing. We know what the limitations will be. We know the way we can accomplish this in the least burdensome or expensive manner possible to try to mitigate any of that burden. So I'm not telling you they're excited, but I do think by and large, their attitude has always been, would much prefer to work with the department than have to try to hash this thing out with CMS or the bureaucracy in DC.
Thank you again. Welcome
Senator
back.
Long, you have a question.
Thank you, Mr. Chairman. I think you may answer this. Overseen by New Hampshire Department of Insurance. Have you heard that the feds may want to oversee partial of this, or I don't?
They would very much like the states to take on the authority and the doing the work of ensuring compliance. In fact, when my team has had conversations with CMS, they've been taking notes on a lot of the work that we've done with regard to transparency over the years. I think, as Dr. Aziz mentioned previously, that is really important. When the federal government first started to get into this space, they had very good intentions and they were driving the conversation in a positive way. What they did not foresee is, once you get all of this information, how do you ensure it is presented in such a way where the consumer can make actual apples to apples comparisons rather than saying, well, what am I looking at here? Because one carrier presents this information in this way, but this carrier presents it in a different way. How do I actually get to the place where I can make that comparison in a way that makes sense? So if you're able to make that uniform across the board, you're going to have a much more robust dynamic that you have, say, on health cost, where you can actually make those, as I've mentioned, apples to apples comparison. It will make sense to the consumer so that they can act accordingly.
Great, thank you.
Thank you.
Any other questions? Thank you very much.
Thank you, Mr. Chairman. Thank you, members of the committee.
So I have a motion and a second. Any further discussion? All those in favor on an ought to pass, say aye.
Aye.
Any opposed? Do I have a motion for consent?
Second.
A second. All those in favor say aye.
Aye.
And Senator Avard will take this out. Okay, Senate Bill 136, establishing uncompensated care assessment fund and committee within the Department of Insurance. I'm going to move interim study.
I'll second that. I'll second that. Thank you.
Any further discussion? I would just like to add that this is an important topic of uncompensated care in mental health. I have started having some discussions with the mental health community and the payers, all of which are in the room today. This is not an issue that's going to go away, but I hope to bring it back later and in a manner that is a little more workable. So with that, all those in favor of interim study, say aye.
Aye.
Any opposed?
For those reasons.
Do I have consent?
So moved.
Senator Avard, second of Senator Birdsall. All those in favor say aye.
Aye.
Senator Prentice, would you like to take this out?
Yes. So, it's like it's fun. It does.
All right. Senate Bill 256. I'm going to move ought to pass,
Second.
and then I'm going to move amendment 20253018S.
Second.
So we got a second from Senator Avard. So just to give you just some background, if I could, this topic is a topic referred to in pharmacy as white bagging and brown bagging. As you recall, brown bagging is the practice where typically the payer would send a drug to the patient, and the patient would be responsible for bringing the drug to the physician's office or the hospital for administration. This bill and the amendment eliminates that practice, and we heard why, a number of concerns why that practice can be problematic. The other practice is the practice of white bagging. The white bagging practice is where an insurer or pharmacy benefit manager sends the drug to the physician or health system for administration at that facility. This is often done in drugs that are considered specialty drugs, or they are expensive drugs, but very often they're all drugs that, in many cases, have special handling requirements and special storage requirements. So we heard in testimony that the practice of white bagging can be problematic, where a facility has a drug on hand and a patient may not qualify for treatment that day due to blood work, labs, whatnot, and then the pharmacy is left holding the bag, for lack of a better word, with the drug. And, you know, but there are reasons why perhaps white bagging has value. And, you know, there are cases where it can decrease the cost of the drug. So the amendment does prohibit the brown bagging, but it sets some clear guidelines on when and how the practice of white bagging can be used. And really, in short, it just ensures that there is communication between the dispensing pharmacy and the where the drug is coming from, the payer. And that is really important. Both, you know, the receiving pharmacy can opt out. There are parameters for that, but it still leaves the door open so that in cases where there may be significant savings to the health plan to use this method of dispensing, that it's not, that the door isn't completely shut to that. If you recall, there was some concern when we heard this bill initially that the hospitals were not included in some of this conversation, or were not aware of maybe an amendment that came about previously. I've spoken with Senator McHugh. I've spoken with the hospitals. They have, this amendment was done together. They both support the amendment, and that's why I brought it forward today. So happy to entertain discussion on this. Oh, Senator Prentice.
No questions. I just want to thank you for the work that you've done, Senator Osher, to get this across the finish line in a way that protects the patients, addresses the concerns that the healthcare providers have had. So thank you.
You. Anything else? So motion is ought to pass as amended. Okay, let's vote on the amendment. So all those in favor say aye.
Aye.
Any opposed? All right.
Pass as amended.
Senator Abar moves ought to pass as amendment. Senator Bertzel seconds that. All those in favor say aye.
Aye.
Any opposed?
Consent.
Senator Abar moves consent.
Second.
I'll give that one to Senator Prentice. We'll give Senator Prentice second to that. All those in favor say aye,
Aye.
Aye.
and I can take that out.
Motion to adjourn.
That does it. So let's move out of executive session. We got a motion, second. All those in favor say aye.
Aye.
Senator Avard has a motion to adjourn.
Second.
All those in favor say aye,
Aye.
Aye.
and we'll close the hearing.
Great.
31 minutes.